Hi, it's Dr. Centeno, and thanks so much for joining us today. Today, we're going to do things just a little bit differently. We're going to start with a lecture. Shouldn't take more than 10 minutes. Now, I normally do that, but this one's going to be a slideshow, and we're going to see how this works and whether or not you like this type of format. Then we're going to go into Q&A, and the Q&A obviously can be about what I'm talking about here today, or can really be about anything that's on your mind. Again, the name of this show that I do twice a week is You've Got the Power. The goal here is to give you the information to take power over your medical decisions. And obviously, that's not on only on this topic, that's on all topics. So you've got the ability to ask questions about whatever you want to know, whether or not it's related to occult tethered cord. So again, new format today, going to do a quick slideshow going over this issue of occult tethered cord. You can let me know in the comments whether or not you like this type of format with kind of a more formal educational lecture and then just opening it up to bigger Q&A. So occult tethered cord, this is an interesting issue because I've seen it come up more and more and more. And it's interesting because while there certainly may be patients that need to get their spinal cords de-tethered and that may benefit from that type of surgery, obviously it's a fairly invasive thing to cut the filum terminale, meaning the anchor for the spinal cord. So we wouldn't want to do that unless we were absolutely sure there was no other way to help that patient, because that procedure is in the irreversible category, meaning that it can't be undone. So let's get into this topic today. I see we've got some folks logging on, so thanks so much for watching. And I will get started here. Okay, so traditional tethered cord, what does that mean? Now, the spinal cord normally ends around L1 or so. So we have the lumbar vertebra, L1, L2, 3, 4, 5, and the sacrum. And so the spinal cord typically ends towards the top of the lumbar spine or the lower aspect of the thoracic spine. Now, traditional tethered cord is a really nasty affair. So for instance, there can be things like a tumor or spina bifida that pulls the cord down much, much further, and or other things that pull that cord down. So this is an easy diagnosis to make, right? You look at the MRI, if the cord terminates way up here at T12 or L1, no tethered cord. If the cord terminates much lower than that, L2, 3, 4, then you start thinking tethered cord. Doesn't take a rocket scientist to make that diagnosis. Now, where it gets into a bigger gray area is when this diagnosis is made, and that's called occult tethered cord or tethered cord syndrome. And this one is much, much harder to figure out. And there's a reason it's hard to figure out, and that's what I want to teach you today, because I'm seeing a lot of patients signing up for this surgery who don't really understand the pros and cons, and they haven't really been talked to about the pros and cons. So I want to make sure that you're educated on the pros and cons of this type of diagnosis. So tethered cord syndrome is a condition that can be present in hypermobile EDS patients. And the concept here is more pulling rather than the terminus of the spinal cord being much, much lower. And the idea is that that can cause back pain, loss of bladder control, lower body weakness, and loss of sensation. Now, all of that sounds pretty reasonable. There's at least one experimental study that shows it may or may not even be possible to do this by pulling on the bottom of the cord. But I'll certainly go for the idea that there may be patients that suffer from this issue clinically. But there's a big problem here in getting to this diagnosis that you really, really need to learn about. And that is that we have patients with traditional back issues like irritated spinal nerves in their low back. And we have patients who have a tethered cord syndrome. And the problem is they share the identical symptoms. So if you've got a pissed off nerve in your back, you got back pain. If it's like an S1 nerve, you can have bladder symptoms. You can have abnormal urodynamics. You can have weakness in your legs, loss of sensation, the whole 9 yards. Now, these are the same types of symptoms that are often discussed in tethered cord. So how do we determine which is which? Because if you have just common chronic low back pain, cutting your spinal cord and de-tethering it is a really bad idea. If you have tethered cord syndrome, and that's the only thing that's going to help you, that might be a good idea. Well, this differentiator is often made on this concept of urodynamics. And just so you make sure you understand what that is, that's when we're measuring the pressure in and around the bladder. We're measuring oftentimes the electrical activity of the muscle that closes off the bladder. And what this test can determine is that the signals going to the bladder that come from the spinal cord are abnormal. Now, the problem with this test is early on, when I was a young doctor, I would see patients come into the office all day, every day, who had, especially women, who had chronic back pain, who had these urinary issues, dribbling. They had frequent urination, all sorts of urinary problems. And I didn't know any better, so I would send these patients out for urodynamics. And almost all of them came back abnormal. They didn't have a tethered cord. They didn't have craniocervical instability. They didn't have anything like that. They just had common back pain. Now, what I learned was that if I did a caudal epidural, meaning I treated the sacral nerves that supplied all of this stuff, their urinary symptoms would go away and their urodynamics would normalize. So I stopped sending my common back pain patients out for this type of testing. So when I hear this idea that this test in someone with back pain is used to determine whether or not we should de-tether their cord surgically, I have to say that horrifies me a little bit, because this test, again, is commonly abnormal in patients with just garden variety back issues. And we have all sorts of publications that talk about how urodynamics can be off when you've got things like spinal cord irritation in the neck. Sound familiar if you've got CCI? Typical low back disc bulges. This is a case report of one at L4-5. And then just typical back pain like disc bulges that might require surgery. And the problem with this is you don't find this as a doctor treating these patients unless you ask that question. And it's not an easy question to ask, right? You've got to ask questions about people's urine and their function of their ability to pee. And a lot of times that's sort of last on the list of what the doctor wants to talk about. They'd rather talk about things like numbness down the leg or your back pain or what makes it better or what makes it worse. So this question frequently doesn't get asked. So how do we know if you have a tethered cord or common low back issues? Well, one's going to be physical exam, right? We can do a physical exam and I can press around on your back and see if it's tender. That might help that. I can look at the function of various low back spinal nerves in your legs. That would also help that. I can look at the MRI and see if it's consistent with someone who has a chronic nerve issue in their back. Even though that MRI might have been read out as normal by the radiologist, there's often still things on there that were not read out. And if I've got any questions, I can do a caudal epidural. That means injecting some anti-inflammatory around those irritated sacral nerves and see if that gets rid of the urinary symptoms. If it does, there's no way this is a tethered cord problem. So these are simple things that can be done, but they often aren't done in this patient population. So we keep patients safe, and I always say this, by offering the least invasive thing that's the most likely to help. So obviously, a caudal epidural, very easy to do. You can do it under X-ray guidance. It takes 5 minutes to do. It's a simple test to see if this is a back issue causing a urinary problem. And then something like the PICL procedure would be more invasive, but much less invasive than permanently altering the biomechanics of someone's spinal cord by surgically detethering it. So obviously, there are patients that may need surgical detethering that have tethered cord syndrome or occult tethered cord, but you'd want to make sure that that was the last thing that you offered that patient, not the first. So detethering surgery, for those of you that don't know, is when you cut the connective tissue that anchors the bottom of the spinal cord to the sacrum, and that's called de-tethering. Now, all of that controls how the nerves move, and it's, I know, hard for many patients to understand, but how your nerves move is extremely important. There is a biomechanics of the normal central nervous system. So if we do that, we permanently alter the biomechanics and how those nerves move. And we don't want to do that if we don't need to. And then we have to ask ourselves, do we have high-level research that these detethering procedures work in this patient population? And the problem is, when you go to look for that research, you see a lot of stuff on detethering in tumors or detethering in kids that have cerebral palsy, but you see very little research on the kinds of things that patients are getting detethered for, like CCI and Chiari and EDS. And when you see that research, it's not really high-level research. I mean, we don't have randomized controlled trials, etc. We only have a few small case series. And I've personally seen some really nice successes and some spectacular failures. So I can tell you what I have seen as a doctor who treats these patients. And for instance, right now I'm treating a patient who I'm assuming needed the surgery. She had actual the bowel or bladder issues that now require or have required where she had to catheterize herself. And so this was more severe than you normally see in this patient population. Now, she had the surgery. She still has to catheterize herself. The first one didn't work. She had a second surgery. And now she's got probably the most bizarre myoclonus I've ever seen, meaning that she, every once in a while, she tends to do this. I can only link it to the second detethering surgery because that's when it began. And it's, the good news is it's not super frequent. It's mostly when she's stressed. The other day we did a procedure on her low back, and she came out of anesthesia like that. And thank God I was not doing anything that could have caused that. And that she told me after the procedure that started happening after her second detethering, because it was pretty disturbing as a treating physician to watch. So who are very good candidates for this type of procedure? Well, number one is, as I've said, all less invasive care has to be tried and failed. And that patient has worsening, usually bladder, but sometimes bowel issues. And the low back has obviously been ruled out as a cause of the symptoms. That's not just an exam or a quick look at an MRI. That's an extensive exam. That's an extensive look at their MRI imaging, more than just what's on the MRI report. And then obviously the third thing would be that you try something like a caudal epidural to see if you can get rid of the urinary symptoms. And if they go away, you're not dealing with tethered cord. Now, some maybe candidates, again, all less invasive care has to be tried and failed, but patients who have Chiari 01, HEDS, widespread pain, some patients that have CCI, etc. And these are cases where we really don't know, but if everything less invasive has been tried and failed, it may be reasonable to do this. So in conclusion, tethered cord syndrome and some forms of common back pain, especially in women, have similar urinary symptoms and positive urodynamic studies. A low back cause for the abnormal urodynamics can be easily ruled out. That's that caudal epidural I talked about. Patients with HEDS, Chiari, widespread pain, CCI should proceed with caution. And it's certainly reasonable to try this procedure if everything else has been ruled out and tried that's less invasive. So as I say, and always tell you, an educated patient knows that you go up on the ladder of invasiveness. You try the least invasive things. If that doesn't work, you go up to the next one. That's a little more invasive. Next one, next one. Obviously, cutting someone's spinal cord is a big deal. So that's what I have to talk about today. Let me go to some questions, and then obviously I'll run back and look at some pictures, etc., if we need to. So Stevie Ann Williams, is it true that CCI can cause tethered cord? Stevie Ann, we don't really know that right now. We certainly have a few neurosurgeons who believe that. And like I said, I have seen some good successes. I've also seen some spectacular, awful failures. So I think the answer is maybe, but we just have to be cautious that we try everything less invasive before we permanently alter the biomechanics of the central nervous system. Submit Advance by Harry Winston. What's the most common cause of occult tethered cord syndrome? It's a good question. I think if you look at the literature, there's not much there. You can certainly find some folks who believe that hypermobile EDS or people with very, very stretchy ligaments may be one possible cause, and or patients who have things like that plus CCI. But again, you've got to be really careful here because the solution is invasive, and you've got to make sure you rule everything else out. Good afternoon, Dr. Centeno. What were your expectations after a 10x procedure for ankle impingement, such as stiffness, strength, range of motion, and so forth? So what we're talking about there is removing bone spurs in the front of the tibiotalar joint or ankle joint for ankle impingement. And the average patient's probably going to have 3 to 10 days worth of swelling and soreness related to that type of procedure. And then certainly by that 1 to 3 week time frame was probably just returning to normal activities. That's generally what we tend to see. Now that's a hard first name. I apologize. Ananya, I'm going to guess. I apologize if I'm butchering that. Can tethered cord be addressed non-surgically, such as injecting the filum terminale with a substance that can make it more elastic? Dr. Klingate says the filum terminale in EDS resembles a bad tendon, so surely it must be a way to fix the elasticity of the filum terminale without removing or cutting it. Yeah, it's a good question. I don't know that anyone has ever investigated that because of the risk of injecting the filum terminale, meaning that would be intrathecal or intradural, and anything we put into that space would go directly into the cerebral spinal fluid circulation up to the brain. So I don't think that that's a really valid way to treat it, or at least not something that would be lower risk because of that. In addition, I think we also need to make sure that we're getting a valid diagnosis of tethered cord, meaning, as I just reported, abnormal urodynamics in a patient with back pain is not a valid way to diagnose tethered cord. So I want to make sure everyone walks away with that concept that if you've got abnormal urodynamics and back pain, you need to rule out the back pain as a cause, and that's not a telemedicine evaluation. That's not quickly looking at the MRI report. That's not a 5-minute, can you feel this neurologic exam. That's a big deal to figure out, but it can be done relatively efficiently if you know what you're looking for. Mark, I had a PRP treatment to my SI joint sacrum lumbar 8 days ago at, I'm assuming that's Centeno Schultz. Would it be okay for me to get activator chiropractic to the sacrum SI joint? Yeah, I think that's just fine, Mark. No problems there at all. Again, just want to make sure that everyone knows you can ask any question. It does not have to be on this topic of occult tethered cord. Regenex, submitted advance by Linda Williams, with the downside of tethered cord syndrome surgery. Well, I can go back to last week. Patient I saw is in a very interesting situation now. She had a tethered or de-tethering surgery. The first procedure she got was an L5 wide laminectomy. And then the second procedure she got was an L4 laminectomy. So she was treated L4-5 and L5S1 with a wide laminectomy, where they then cut the cord. Now, what she ended up having after that was a possible dural leak. And in that, she now has cerebrospinal fluid that leaks out into her paraspinal muscles because of these detethering procedures. So she's in a really bad spot right now. Not only does she have the new symptoms I talked about, which are these bizarre myoclonic jerking things, but she's also dealing with a scenario where, because of the detethering surgery, she has a whole host of new problems that may not be solvable, meaning that the back part of the dura was removed as part of these surgeries, or collapsed or degenerated. Either one doesn't really make a difference right now, because her cerebrospinal fluid, rather than being contained in the spinal canal, is now all over her low back muscles. And so trying to get her back to normal is going to be interesting, because we're dealing with the fact that her spinal canal is now open to the outside world. So I'm trying my best to help her, but I don't know if I'm going to be able to, but I'm certainly going to try. And again, I apologize if I'm messing up your first name. Ananya, would getting PICL prior to surgery ensure that CCI doesn't worsen after surgical phylum terminale release? I think that's what that means. Would getting prior surgery. Yeah, again, Ananya, that's not a good idea to layer it that way. You're doing a much more invasive procedure and then doing a much less invasive procedure. So I don't, that's just kind of a backwards way to do it, because you're exposing yourself to much more risk than you need to be exposed to. So if for some reason you wanted to try a spinal cord detethering after PICL, that would be a pretty reasonable thing to do, as long as we actually have a solid diagnosis of a tethered cord, which again is not urodynamics. It's not a quick back exam, and it's not looking at the MRI report. It takes a little bit more than that. So again, just be careful, because you're ordering those things backwards and exposing yourself to much more personal risk and the chances of a bad outcome than you really need to. JVic, have you emerged or noticed a timetable for these symptoms to emerge? Is it immediately or possibly comes on gradually? Jay, maybe if you can give me a little bit more color on that one. I'm not quite sure which topic you're referencing. As far as occult tethered cord, or are we talking about other things? So maybe put a little bit more there. Phil, following on from your vid on Monday, cartilage damage in facet joints looks difficult to observe by MRI. Can it be identified by DMX X-ray inflection with PRP injections heal damaged cartilage? So you're right. On MRI, it's very hard to identify. Probably not going to be identified on DMX or X-ray inflection, anything like that. It's primarily based on clinical exam and that joint's response to treatment. And things like PRP and or bone marrow concentrate within those joints may help heal the cartilage damage, but a lot of that's going to depend on how severe that is and realized we can't really see that well on MRI. So best we can do is to treat it. Does the filum terminalis serve a purpose in mitigating CCI? In that case, is it best to stay tethered? The filum terminalis shouldn't have anything to do with anything with CCI, meaning that based on the biomechanical studies, for instance, they tried to see if they could pull on the filum terminale to cause a Chiari. They couldn't do it. The reason was that the filum terminale was too flexible, and because it was too flexible, it didn't change anything up here in the brain. So because of that experiment that was done, I don't think that anything regarding to the filum terminale would have much to do with CCI as far as staying tethered, not staying tethered, etc. Kristen, this was so helpful, great topic. How do you treat antilostosis in a patient when you cannot inject the PLL? Yeah, the most common treatment for antilostosis, and this would be a good chance for us to do show and tell, because you know I love show and tell here. Let me get to PubMed and then share my screen. Okay, so PubMed is the U.S. National Library of Medicine. So this is a paper we published a long time ago. Let's see if I can find it using those. Nope. Let's take out some of that. Here we go. So this is a paper we published in 2005. Man, I'm feeling old. What is it, 2022? So this was almost 20 years ago at this point. But the bottom line is that we had patients that had anterolisthesis in flexion. All we did here under X-ray guidance was to inject the supraspinous interspinous ligaments, and we got that to go away. We didn't have to inject the posterior longitudinal ligament at all. So this is the paper that shows that if all you do is inject the ligaments in the back part, supraspinous interspinous, you can make that kind of anterolisthesis go away. Ananya. Can a laminectomy create spinal instability? Yes, absolutely. So in a laminectomy, let's look at that for a second, because that's a really good question. Really good teaching point. So if you look at the images of what a laminectomy is, so this is maybe a good one here. So a laminectomy is unroofing the back of the spinal canal. And when you take off the back of the spinal canal, what tends to happen is that it's very easy to get into the medial part, the inside part of the facet joint, and to remove that as well. And so that destabilizes the segment. And that's one of the causes of what's known as post-laminectomy syndrome, meaning chronic pain after laminectomy. So yes, a laminectomy can cause local instability there. Cian, I tried reaching out to your team. I'm getting scans since next week on Tuesday. Do you have an email I can contact you on, if you don't mind, please, so you can read my scan results? Sure, I'm not quite sure what it is we're talking about there as far as a scan goes, but my email, I think I've given it out before, but I'll write it down here on the comment. So Centeno office at CentenoSchultz.com. I think that's right. Whoops, let's take the O out of there. So I'm putting it in the comments right now. That's the one that goes to my desk. So if you want, happy to, send me a quick email. I'm not quite sure what scan we're talking about, but if it's a simple thing to do, I'm happy to take a quick look, let you know what I see. Now that doesn't substitute for an actual telemedicine exam where we look at everything and try to see what the best thing is to do for that patient. Phil, I'm 10 days post-PRP, dialgo cells, C0, C1, 2, 3, 4, and mean improvement for the first 3 days, then return to baseline. What physio exercises will aid ligament healing? Any exercises to avoid? Well, number one, great that you got treated there. I have certainly referred some of our European upper cervical patients there who I think might get better with just upper cervical facet and simple prolotherapy type injections in the ligaments. As far as exercises to aid ligament healing, no specific exercises to aid ligament healing. If you have a loss of normal curve or loss of lordosis, we recommend curve restoration. So I don't know really your case there. So you may want to double back around with the doctors there. Outside of that, it's really activity as tolerated. Does C1, C2 worsen occult tethered cord? That's a really good question. And I think it's worth talking about because there's certainly talk, as you know, in the CCI community about the concept that you may need to have your spinal cord de-tethered if you have a upper cervical fusion. And I think it's, see if I can draw some pictures here. Hold on a quick second here. Okay, so let me draw some quick pictures. See if I can get this done in a reasonable time. It's not gonna work. Okay, that'll work. So let me switch the share. Okay, so we have here a head, and we have here a spine. And one of the things that can happen with upper cervical fusion is if it's done with traction, the head tends to get pulled up a bit. And I'm going to totally exaggerate here just to show you what I'm talking about. So the head tends to get pulled up a bit. And obviously, if you then fuse it in that position, so I'm going to create something that doesn't look anything like a fusion, but hopefully you'll know what I'm talking about. So if you fuse it in that position with something like this, then you've now created more tension on that spinal cord because you've pulled the head up and the brain is in there and that's connected to the spinal cord and it goes all the way down. So I think there's some reasonable thought process that if you use traction during your upper cervical fusion surgery, then you're increasing the pull on the spinal cord. So that might be a real reason to consider de-tethering surgery if you can prove that that's what's causing the problem. There's some patients, and it's been very few, a handful now, who I think are very vocal, who also claim that if we stabilize your upper neck with PICL, you might need de-tethering surgery afterwards. And I can say I maybe know 1 or 2 patients that have done that and done well. I know 3 or 4 who have done that and crashed and burned. So is that a thing? I don't know at this juncture. But again, we wouldn't want to do it unless we really knew that that was the issue. Steve Ann Williams, do you know if styloids can only become elongated due to CCI or can they generally be longer without CCI? Aha, more show and tell, Stevie. You're giving me all sorts of reasons to share the screen today. So thank you for that. So if you go to the Regenx blog, let me go and do that here. So if you go to regenx.com, go to the blog, and you go to the search function up in here, and you type in Eagle syndrome. Hope it'll come up under that. Yeah, what is Eagle syndrome? This blog talks about the anatomy of what it is we're discussing here. So let's go over this, because this is probably worth a lecture in and of itself, and maybe we'll do that on Monday or next week or something like that. But so we have here the styloid process, and the styloid process is this little thing that comes off the side of the skull. But we're really not seeing an elongated styloid process. That's kind of a myth. We are seeing this stylomandibular ligament, which attaches to the styloid process. And that stylomandibular ligament can become calcified. And that's what appears to cause an elongated styloid. Now, the problem is the research shows here that about 4 to 7% of the normal population who has no problems at all are walking around with elongated styloids. And of that 4 to 7% of the population, only 4% of those people have an Eagle syndrome. So we have better than 90% of the patients walking around with an elongated styloid who have no issues at all and who do not have Eagle syndrome. So we have to be really, really careful. There's an awful lot of patients walking around out there with elongated styloids who do not have any problems or issues. As far as can they become elongated, it would be more, can the ligament become calcified in CCI patients? And I think the answer is yes, because that ligament is getting yanked on in CCI patients. So again, it's not so much that we have this long styloid, is that we have the ligament attached to the styloid that then calcifies or turns to bone. So it looks like an elongated styloid. And yes, in CCI patients, that ligament is getting yanked on all the time. And when the ligaments get yanked on all the time, in some patients, they turn to bone. Kristen, my myodural bridge is infolding on MRI. I know that this ligament and can be injected, but will my dural tension muscle dysfunction need to go away in order for it to heal? What does the tugging do? Yeah, really good question. Again, another great reason to share the screen here. Let's see if we can look up myodural bridge here on the Regenix blog, because I got 3,000 of these blogs. Now, I may not have covered the topic yet, but if you had to bet, I probably have. So this is a good place to go to get this kind of information. So if we go to the Regenix blog, let's try this one. Rectus capitis posterior minor and the myodural bridge. That may not be it. Okay, so this is a really cool Scott Rosa, and I'm going to put a plug in for Scott Rosa here. If you want someone that's totally jacked in to understanding CCI, Scott Rosa is your guy on the imaging side. So this is one of Scott Rosa's amazing moving MRIs. And what this shows is the problem, but you're going to have to look for it very, very carefully to notice it. So let me see if I can make my cursor bigger here. See if that's possible. I've been wanting to do that on this computer anyway, so I'm going to take just a second to do that so you can see it. Okay, we're good. So hopefully now you can see, well, I guess I can only see it. You can't see my cursor any bigger. Anyway, sorry about that. So as this person, so what does the myodural bridge do? What it does is it allows you to extend your neck. And when you extend your neck, its job is to pull the dura, or the covering of the back of the spinal cord, out of the way. And when it doesn't do that, you tend to get infolding here with extension. So you have to look at the very, very top up in here, and you're going to see a little bit of a bump out as the person gets to here. And that bump out can cause problems with flow in the cerebrospinal fluid that can be worsened if you have a low hanging back of your brain called a Chiari 0 or a Chiari 1. So again, it opens that area up. Now, and actually I stopped it here, so maybe we can see that a little better. So this is the usual patient on the right when they extend their neck. You can see that it's nice and smooth in the back part here. Then we get to the patient we talked about above, and you can see that where the myodural bridge jacks in to the rectus capitis posterior minor muscle, regrettably, this is bumping out. And it's bumping out because the muscle isn't doing its job. Now, that could be because the muscle is weak and can't do its job, but often it's because the tendon attached to that area is tendinopathic or pissed off. So treating the tendon can help the muscle and tendon function correctly to get rid of that extra bumping out. So the goal would be to treat the tendon to calm it down. So just to make sure we're understanding that, treating the tendon will actually help it function to pull that stuff out of the way. So it shouldn't be a concern about treating that tendon. Ryan, what's the best way to get in touch with your team, RE, telehealth for CCI? You know, I think the best way, I'm going to give you my assistant's direct line just to make sure that all this happens smoothly. So I'm writing it down here, and her name is Carla. So it's ksolis@centenoschultz.com. Send her an email directly, and she can help you figure all that out. That way you can kind of get the VIP treatment, so to speak, where she can make sure that happens for you. Ryan, I submitted a form on the website a couple weeks ago, but haven't heard. Yeah, Ryan, like I said, I'm gonna help you bypass all of that and get directly in with Carla, who's my assistant. So that's her email is down there in the comments. So look at that and reach out to her directly. Just tell her I told you to reach out to her directly because that's going to bypass a lot of that machinery. So I apologize for that. Ananya, thanks so much, doctor. The information is so empowering. This is my last question. I promised. Did lax ligaments of EDS counteract any long-term benefits of PICL? Yeah, so it's a good question, Ananya. We have about 1 in 5 of our patients right now, sometimes 1 in 4, that have EDS. So far, we haven't seen them doing any worse or better than any of our other patients. Now, last time we looked at that analysis was about 4 months ago. Sometime this summer, we'll look at it again and see if there's any trend emerging there. But right now, we don't see that connection, but we'll certainly let you know if we do. Kristen, can you have interlisthesis not inflection and resolve the same way? Yeah, Kristen, I think what you might be referring to is a fixed anterolesthesis. So that means that one vertebra is forward on the other, and that's not changing or moving in any way. Now, if it's fixed, then injection-based treatments are going to be less likely to help. And it's usually fixed because it's been there a long time and there's changes in shape of the bone. So I'd need to look at your imaging to be able to tell you which it is, but it could be fixed. Phil, I did 10 weeks of curve correction with Dinerol, PRP, pre-PRP, however, changed cervical spine minimal, which is still military neck. How long after PRP procedure? Yeah, you can go right back to that, Phil. So there's no real issues there. And so that's a good thing to bring up too, because I think that's a common question. So maybe I can zoom out of this crazy thing. But if we look up those cervical ligaments, so let's do that. So we're talking about those cervical interspinous and supraspinous ligaments. So I'm going to try to make this screen bigger so you guys can see it better. And I'm going to have to go over here. So hopefully you can see it. So this is the kind of thing we're talking about. So The supraspinous, interspinous ligaments happen in the back part of the spine in the neck. Now, those are also the ligaments that can help to support a curve. And another picture to look at is this one here. So they go in between the back of the spinous processes there. And if we can tighten those via injection, then that will hopefully lead to something that will support that increased curve. So by all means, adding in Adenoral to that type of treatment, as long as it doesn't aggravate things, can be synergistic, because on the one hand, you're trying to tighten the ligaments to support the curve. On the other hand, you're using Adenoral to also try to open up the front part here that might be tight. So by all means, combine those. Becky, how do you treat tethered cord non-surgically? Well, the first thing is actually getting an accurate tethered cord diagnosis. And I have to tell you, Becky, I've got serious concerns that that's actually happening right now. So that would mean that if you've got back pain, the diagnostic process that I just outlined is followed. So that means a review of your MRI images and not your reports. That means a hands-on physical exam of your low back. And that means if you've got bladder symptoms, a caudal epidural to see if they go away. So if you've passed all of that and you still think you have tethered cord, then the first thing would be to treat whatever it is that's causing tethered cord. So that might be something like craniocervical instability. So get that treated first, and less invasive there would be PICL. And then if that doesn't work, you can always get your spinal cord de-tethered. But you have to realize that the de-tethering surgery is much more invasive than any injection I or anyone else can perform. So you can't start there. I mean, I guess you can. It's just not a good way to keep yourself safe. Phil, hi, Dr. Or sorry, Paul. Apologize, Paul. I know Paul. Hello, Dr. Centeno. Do you require any imaging to inject the TMJs or the hips? I experience popping and cracking noise on a daily basis in those areas. You know, Paul, a lot of that depends on the type of issues you're having. Why don't you drop me a line privately via my email, which I put just a couple of comments up there, and let me know what you're experiencing, and I can tell you whether or not I need any imaging or not. Obviously, if I can save you imaging, I'm happy to, but drop me a line on that. Becky, does tethered cord cause brainstem compression symptoms? Yeah, Becky, that's that research I was talking about. So what these researchers did is they were investigating the concept that a tethered cord could cause pressure in the upper neck and lower brain. So let's think about that for a second here, and we'll see if I can pull up some pictures. So let's look at Chiari malformation. And there's a kid shown here because normally we're dealing with this in kids. So the concept here is that the back of the brain can get pulled down into that Chiari position, and that's happening because there's pulling on the spinal cord. Now, when they tried to go ahead and test that, what they found is that when they pulled on the bottom of the spinal cord, it was elastic enough where they didn't see any change in anything happening in the brain. So based on that research, I would say at this juncture, the answer is probably not. Now, that doesn't mean there aren't people who maybe had a Chiari before, because again, we have to realize that there's a huge number of people walking around out there who have no problems at all and have a Chiari malformation on their MRI. So the question's always been, how do we differentiate those people between who have a symptomatic Chiari from an asymptomatic Chiari? And most of them are asymptomatic. So it's possible that if someone had an asymptomatic Chiari, which is 99% of them, and then got some pulling, perhaps those two things can cause issues. that hasn't been investigated. But again, the only way to see if Chiari is causing your problems is to open a hole in the back of your skull and to see if you get better. Obviously, that's got to be put on the last thing on the list to do, because once we carve a hole in the back of your head, that's not pretty. And beyond not being pretty, there's some real reasons why we don't want to do that. So if we go back to the Regenx blog and we look up decompression, I've got a picture of that. Anyway, it just shows a hole in the back of the head. So we don't want to put a hole in your back of your head unless that's absolutely necessary. Can you explain what to do if tethered cord occurs in the neck, what symptoms it causes? Yeah, I did that earlier on. So the most common symptoms for tethered cord would be back pain, bladder issues, weakness in the legs, changes in sensation, etc. The problem with all of that is that all of that intersects with or overlaps with just common chronic, excuse me, chronic nerve issues in your low back. So you can't go ahead and make that diagnosis based on urodynamics. So I want to make sure everyone walks out of here understanding that concept. That if someone's telling you they can diagnose a tethered cord based on abnormal urodynamics, you can't, because common low back nerve problems also cause abnormal urodynamics if it's the right nerve. So that's why I talked before about that concept of needing to have things like a caudal epidural as a tiebreaker. So treating those irritated nerves in your back. Becky, can stem cells help burning and tingling in the legs? Yeah, I think we're talking here about radiculopathy, so irritated nerves, and we treat irritated nerves all day, every day, usually with what's called a platelet lysate. So usually stem cells are not needed to treat that type of thing. If it's coming from the low back, we treat the low back usually with platelet-based treatments to get rid of that problem. So the answer is yes, we treat that all day, every day. Algal cells in the UK, that's for someone else there. But yes, that's what we're talking about. I think they're in London now. That's my assistant's email, ksalas@centenoschultz.com. So if you're experiencing any difficulty getting through the call center or getting on the schedule to do a telemedicine visit, just reach out directly to Carla, and she can get you sorted. She can bypass all of that stuff. So ksalas, S-A-L-S, at centenoschultz.com. Becky, have you ever treated anyone with a unilateral alar severe and complete tear? Yeah, Becky, it would depend on what you mean by a complete tear. It would depend on how that was diagnosed. So what I mean by how that was diagnosed is the alar ligament is not easy to see. So what we're discussing there is getting the right kind of MRI that would show that, which is a very specific kind of MRI with a head coil. And then would have to document on a movement-based image like DMX that there was severe overhang to one side that wasn't present on the other side. So getting that diagnosis is not just doing an upright MRI, because an upright MRI would not have the definition to show that type of thing. We need a 3 Tesla closed bore MRI with a head coil, and then a DMX to follow up to get to that diagnosis. And then it depends on what kind of complete tear you're talking about, meaning complete retracted or complete signal change. Complete signal change, yes, we treat those all day, every day. Complete retracted, I've only seen that a handful of times, and it's extremely rare, but it's not a diagnosis that can be made with an upright MRI. Camille, how many weeks does PRP treatment usually take? Camille, I'm not quite sure what you're asking about being treated. So if you can just give me some more information there, that'd be great. Becky, have you ever treated him with broken vertebrae? I think what you're probably talking about, I'm hoping here, is an old compression fracture perhaps in the spine. Yeah, about 5 to 10% of our patients have old compression fractures in the spine. Those are very, very common. If it's something else, please let me know. Shanze, have you seen cranial sutures being loosed in any patients, and can PRP help that? You know, Shanze, that's more of a manual diagnosis made by a craniosacral provider. It's not something that we can image. Let's say I know most TMJ ligaments can be assessed externally, but have you done? Yeah, I think Shanze answered this last time. And the answer is we can get to where we need to from this direction. Once or twice we've had to go into the mouth to inject TMJ ligaments. But since pretty much everything can be accessed here, there isn't often a pressing reason to come in from the other side. Spina advance, 10 years ago, I had craniotomy for sphenoorbital grade 1 meningioma. Tumor cells invaded the right greater sphenoid wing and also into some of the lateral orbit. The wing and other bone were drilled out. My 5-hour surgery turned to 8 hours, and I hemorrhaged 3 units of blood during the removal of the bone. My head was in a Mayfield pin headset extended left 30 degrees for that time. I think there's more to that. I don't see the more yet, so hopefully we'll get there. Becky, do any of these conditions and comorbidities cause bilateral ptosis? It's possible, Becky. I'd have to know, again, what level of eyelid drooping we're talking about there. Our stem cell counts, total counts, do they represent concentrations? If you're injecting more sites, would you draw more bone marrow? Would it result in a higher stem cell count? Yeah, Jalal, so we're talking about total nucleated cell counts often. So that's the total number of cells, of which the stem cells are a fraction of that. And if we need more stem cells, we can obviously draw more volume, obviously up to a limit. Is it common for radiologists to miss tethered cord on spine MRI? Kelly, just realized that the kind of tethered cord we're talking about here cannot be diagnosed on a spine MRI. There's no way to diagnose that. So the diagnosis of traditional tethered cord is when the bottom of the cord is way, way too low. And occult tethered cord, the bottom of the cord is in the usual position. So we really can't diagnose that based on an MRI. So a radiologist isn't going to read that because it's generally not possible to get there on that kind of image. Becky, does C1 and C2 fusion or PICL solve Chiari and syringomyelia? Becky, the problem isn't solving Chiari. Listen, I think it would be really good if you watched this YouTube video. Let me see if I can find it for you here. Okay, let me try to find that for you. Okay, so if you go to my YouTube channel and you were to type in CCI, this video, symptomatic Chiari malformation and CCI, is a good one for you to watch because it talks about the fact that Chiari malformation is a normal variant of the adult brain. So 90-some% of the patients walking around with a Chiari malformation have no problems. Then you have to ask yourself, why do some people have problems? And the theory now is that instability plus Chiari can cause symptoms. So if you get rid of the instability, you don't need to do anything about the Chiari in the vast majority of patients. So that's the focus there. But again, it would be really good if you were to watch that video because I think it explains all of that. What are plate lysate and how do they do? Yeah, so platelet lysates are derived from platelet-rich plasma. We take platelets from platelet-rich plasma. We break those open to get the growth factors out. Another question, is the Tarlov cyst a common culprit for CSF leak? Not usually. Tarlov cysts are pretty common. Now, they can cause local problems when they compress a nerve. So just realize that now what Tarlov cysts can indicate, if you've got a lot of them, they're more common in EDS patients. So, and CSF leaks are more common in EDS patients, but a Tarlov cyst in general is not associated with a CSF leak. Does C1 and C2 fusion always cause? So it'd be the opposite, Becky, unless you're talking about adjacent segment disease, meaning CCI might require a fusion. Now, if you get C1 and C2 fused, you can get CCI above that, or adjacent segment disease. So maybe that's something that you're talking about. I'm going to try to get back to W.C. Hurst here, since I haven't really finished his thing, and then I probably need to rock because I've got a 2 o'clock and it's 2:01 p.m. So I'm going to try to finish W.C. Hurst's question here. My symptoms started about 11 or 1.5 years later, but not primarily in the head neck. It started as running injuries to the left foot, left gluteal tendon tears, hamstring, etc. PT was quite hard for me. PTs were all confounded that I was difficulty recruiting the proper muscles, incredibly tight neck, shoulder, hamstring muscles. And then W.C. Hurst, they would all comment that they could get my head and spine back in alignment, but as soon as I stood up, it all collapsed. I just couldn't hold an adjustment. After 14 PTs, a few chiros, manual cranial therapy, acupuncture, many other treatments, I really began to decline in December of 19. I developed involuntary movement, seizure-type symptoms, worsening vision that could not be corrected, brain fog, unstable gait, balance, disabling headaches, poor grip. And then finally, I did, and they have me go on antidepressants and do neurofeedback. After 3 months, my symptoms were worse. So I DC'd the treatment. All neurodocs agree that there is no impairment of the cranial nerves. Recently, I found that my tongue deviates left when sticking it out. So that would be a cranial nerve 12 issue. There's more to my history, but due to time constraints, I will admit I've consulted my neurosurgeon. There's no return of the tumor. Yeah, so I think W.C. Hurst, it all sounds interesting. Certainly what can happen is if you've had to have your head in that position, certain ligaments may have been damaged, and that could lead to CCI or other damaged things that are causing a change in how you perceive what's straight up. So at this juncture, I would say, sounds like a great reason to do a telemedicine evaluation. I would reach out directly to Carla. Her email is above there. And hopefully she can get you sorted out and we can try to help you figure this out. Guys, I do have to go. Just because I've got a 2 o'clock and it's 2:03, a 2 o'clock meeting. Again, we'll try to see if we can copy these over to the next one of these we have, or just show up same bat time, same bat channel on Monday at 1 o'clock Mountain. And again, if you want to get on the schedule, reach out to Carla directly. That'll bypass a lot of the stuff. She can help you get sorted out. And thanks so much for watching, guys. I apologize I couldn't get all the questions, but there were some great questions today, some great teaching points so that people can feel empowered about their healthcare. So thanks for that. And you all have a great weekend, and I'll see you back here on Monday. Thanks so much.